Good afternoon, ladies and gentlemen. My name is Julie Gosla, and I'm from the International Food Policy Research Institute. Thank you very much, everyone, for coming. I know it's a formidable task after lunch, when we're all super nourished, to be able to come together. But we have a really exciting session. Personally, I'm most invested in this session. I find it to be among the most timely, so thank you very much for joining us. So it is my privilege to be able to introduce our session co-chairs for today's session on digital solutions for diets and nutrition. First, I'd like to introduce Indra Chetri, who's the Content Marketing Officer for Africa and Asia with Helen Keller International. He has led the social behavior change communication and outreach communication for USAID-funded Sahara 2 and USAID Integrated Nutrition. He holds an MA in Journalism, Media, and Communication from the University of Dhaka and has been working in Nepal for over a decade, specializing in development communication, SBCC, media development, and storytelling. So please put your hands together and welcome Indra. And we also have Prajuna KC, who's the Country Director of IDE Nepal. She brings 15 years of experience across development and private sectors, combining management expertise and technology-driven solutions to advance sustainable, scalable impact and deliver meaningful change at IDE. Thank you very much for joining us. It's a privilege. Please put your hands together. Without further ado, over to you.
Namaste, good afternoon. A very warm welcome to everyone present in Koshi Hall and our colleagues who are joining us online. As she mentioned, it's a formidable task to have everybody here, but hopefully you're well nourished and not to sleep because we have an amazing line of presenters coming up. It's my pleasure to co-chair the session on digital solutions. As she was mentioning, it's very close to my heart as well, somebody who has been very invested in creating digital solutions, creating digital platforms. I'm Prajuna KC, as she introduced, I'm the country director at IDE, and I'm honored to share this role with my co-chair, Indra Chetri from Helen Keller International. This session focuses on an area that's very close to my heart, and I think very central to our conversation about having a collective impact on health and nutrition, the power of digital technologies to drive impact at scale. Across South Asia and especially in Nepal, we work in contexts that are defined by geographic difficulties, whether we are talking about rural settlements, limited infrastructure. But paradoxically, it's also a region where we are increasingly seeing greater internet connectivity and digital technologies. The combination, challenge, and opportunity makes digital innovation not just useful, but essential. As we all know, nutrition challenges we face today are not static. They're evolving as our challenges that are evolving, whether we are talking about climate change, immigration, market shifts, and generally how we are consuming information digitally and how our food systems are working. This means our solution must evolve. We cannot rely on traditional approaches when technologies are changing in how we consume, how we learn, how we eat, and how our behaviors are changed. We must continue to innovate, test ideas, refine digital tools so we remain relevant. At IDE and certainly across many of our organizations, the mindset drives our everyday work, using technology not just for the sake of it, but to solve real problems for real people at scale. From my experience at IDE, we've seen how digital tools can bridge long-standing gaps in access and information, whether it's mobile-based farm advisory apps, digital marketplaces, weather-indexed digital insurance, or interactive digital content supporting behavior change. These solutions extend our reach far and beyond. But, I would like to quote my son's favorite superhero, he was Spider-Man. He says, with great power comes great responsibility. As we are learning to build the power of digitization, it comes at a huge price of ensuring it comes with inclusivity, data protection, cultural relevance, and keeping equity at the center of it all. Today's presentation offers a rich demonstration of how diverse and creative digital nutrition solutions have become across our region. Whether it's Quran-based digital messaging, AI-powered dietary assessment tool, or digital nutrition registries. Together, these insights remind that digital approaches are not only shaping service delivery, they're also shaping our social norms, dietary environments, and long-term health environment. I want to once again acknowledge all our presenters for their commitment and their willingness to share their work with us. Each of you are contributing an important piece to the puzzle of how we can use digital strategies more effectively, and for all of us to understand how we can accelerate digital technologies to drive impact at scale. Thank you again for participating from across countries and sectors. With that, I'm delighted to hand it over to my co-chair, Mr. Indra Chetri, who will guide us into the presentation and introduce our speakers.
Thank you so much, Prajannaji. In the interest of time, we'll go directly to the presentations. But before that, I'd like to make two requests. One to the participant. This is a reflection from my 1.5 days of sitting in the back of the rooms. Please minimize as much as possible the chat with each other, because that not only it disturbs everyone else in the room, because we're a very small room here, number one. And to the presenters, I'm sure your presentation is already ready and you've saved it, but as much as possible, try to reduce the use of jargons and acronyms, because there are less technical or non-technical people like me in the room. Thank you. So I'd like to invite, for the next presentation, I'd like to invite Rina Mattinson from Weltinga Railway. She'll be presenting on empowering communities via digital Quran-based campaign, advancing nutrition and disability inclusion for health and equity in Afghanistan.
Good afternoon, everyone. Welthungerhilfe, or WHH, is the German-based NGO with an audacious goal. Is it me? Am I electric? Can I restart the counter? Is that okay? Okay. Start again. Welthungerhilfe, or WHH, is a German-based NGO with an audacious goal of zero hunger by 2030. So in the context of Afghanistan, with 17.4 million people projected to be in crisis or emergency phases of food insecurity by this winter, it's no wonder the country has one of the world's highest rates of stunting, at 41% in children under 5. As of August, wasting was recorded at 9.5%. 1 in 3 adolescent girls suffers from anemia, and it's the same with mothers who are equally malnourished. Now in Afghanistan, WHH takes a multi-pronged approach. We do a lot of humanitarian response with food distributions, multi-purpose cash assistance, and fresh food vouchers. But we also work on trying to improve agriculture and household-level food production through distributing emergency agricultural kits, promoting household-level food production, and helping households develop more resilient non-farm and off-farm livelihoods. But there are also significant cultural barriers to improve nutrition. The statistics tell us that only 12% of Afghan children aged 6 to 24 months receive the right variety of food in the quantity needed for their age. And only half of Afghan babies are exclusively breastfed in their first 6 months. The Afghan diet culturally does not contain much variety, so we run a lot of cooking demonstrations, with women teaching them how to prepare the new vegetables that they're growing and what a nutritious family meal looks like. We also train the men on the value of varied diet, so they are more inclined to purchase a wider variety of fresh food when they have the resources. Now, you may be aware that the Taliban took over Afghanistan in 2021, and the Supreme Leader has been issuing edicts ever since. Some of these edicts are banning girls from education above grade 6, but the one that impacts us the most is banning women from working, especially for NGOs. We assess the risks on a daily basis, and our female staff can usually still work in the field, but it's increasingly difficult for them to come to office. And it's increasingly difficult for us to reach women in the community with any level of integrity. So we're always looking for contingency plans on how to deliver our programs. So about a year ago, we saw an opportunity through one of our EU-funded consortia projects to trial a complementary method of spreading nutrition messages. This project is called Faragir in Dari, meaning inclusive in English. We had 4 consortia partners covering 6 provinces, targeting 6,000 households, with the aim to safeguard the livelihoods and food security of the Afghan population and mitigate the impact of the humanitarian crisis. One of the consortia partners already had a strong methodology for working with the local mosques and religious leaders. So we saw the opportunity to pilot a digital approach to spread information on nutrition and disability inclusion across the whole country, and then following up and pairing that with community interventions. WHH had actually prepared the nutrition messages with the Ministry of Public Health in 2020 under the Republic. So we weren't really sure how the new authorities would see the messages, especially the new human rights and disability inclusion messages. So we coordinated the activity as close to the ground as possible and shared the messages at the provincial level with the Ministry of Hajj and Pilgrimage for their approval. We then contracted the digital service provider, Viamo, to record the messages and roll out a nationwide digital awareness campaign, delivering 20 Hadith-based key messages via the free mobile service 234. It provided pre-recorded, culturally relevant messages in local languages through engaging sound bites over a 6-month period, focusing on maternal and child health, breastfeeding, hygiene, family support, and reducing stigma. The process was designed for simple analog phones, and this is just the outline of the 3 button pushes that the people had to select to be able to hear the messages. So we were pleasantly surprised by the results. Over the 6 months, over 66,000 callers listened to almost 120,000 messages. So that was an average of 1.8 messages per caller. The caller conversion rate, so those that rang and then stayed on the line to listen, was between 85 and 90% of callers, and 56% of the listeners were male. Also, 44% were female, which is actually a very high number, given the difficulties that many women have facing accessing phones. A report from GTS Salma last year found that 62% of women and 65% of older persons in Afghanistan do not have independent access to phones. So 44% access was great. There was not a great difference in the popularity of the different messages. The most listened to message was listened to 1,339 times, and the least listened to message was listened to 1,203 times. I've listed the top performing key messages there. Hopefully you can read them with that size of text. Now, this is a lot of data, but this is the report that we would receive each month outlining the key messages, how many times they were reached, how many times they were listened to, and the breakdown of male versus female listeners. And you'll notice that the gender balance is quite even across the messages. Notably, messages 7 to 12 addressing social norms such as equality, stigma, and support for persons with disabilities also perform strongly, signalling audience receptiveness to broader social issues despite the government edicts. Now, I don't read Arabic, but here is an example message, and I'll just leave it up for a moment for you to read and get the gist of what the messages looked like. So, what did we learn? I'll start with the weaknesses. First, the messages were not detailed or targeted enough. They were adequate for a complementary activity, but they were not adequate without follow-up in person. We could have made the messages targeted by providing phone numbers and paying for a call-in or a pull service, but it costs significantly more, and collecting and sharing phone numbers is a high-risk activity in Afghanistan from a data protection perspective. Secondly, it was only available through one phone company, which was the largest phone company, but that means that there was gaps in coverage, or that callers from other companies had to pay to access the service. There was limited promotion, but that was largely due to budget constraints, and it was difficult to measure real-life practice change. This was the biggest issue. For a fee, we could have called back and conducted a self-report on practice change, but that could have undermined the trust that we had with the participants, and it was not really accurate enough for the cost. The strengths, however, we felt were worth it. It was cost efficient, it was accessible, and it was a complementary sensitisation tool. In the context of not being sure if we can reach women tomorrow or not, it was a great fallback for our programming to make sure that we could actually get some messages out to women. We were surprised at the higher reach of men compared to traditional methods. I've got 1 minute left. Okay. Okay, thank you. And it sidesteps national level politics, which in Afghanistan is a good thing. If you're not stuck for 3 years arguing with bureaucrats, that's great. And most importantly, the messages are within the cultural and religious framework. So for the community campaign, the nutrition and crime messages were shared with the local mullahs and the consortium members. And we ran a big workshop at the provincial level with community leaders, the mullahs, community influencers, and the Directorate of Hajj and Pilgrimage for their comments and feedback. And they were surprisingly fully supportive at the field and provincial level. In WHH's project location, we had 40 community volunteers, and they would do the awareness raising, they would conduct the monthly sessions through the mosque, and then they would report back at the end of each month. And they reported back that the community were really open to the messages, really interested in the messages, and happy to implement them. What's most important from my side is that the project manager noted that the coordination with the Ministry of Hajj built a level of trust that we don't have in other projects, and was likely the reason why we were able to have women in all our project sites for this project implementing the project. So, implications for scaling and policy. A digital intervention such as this would be most appropriate in collaboration with a government program or a large player who has programming countrywide and can provide on-ground follow-up countrywide. Unfortunately, we weren't able to do that. Alignment with government strategies would be great if that's available to you. And scaling requires partnerships with nutrition, health, education and social protection sectors, and collaboration with private sectors for digital access. Finally, we learned a lot from this pilot, and I don't regret running it, but to be honest, I don't think we would run this at such a broad scale in Afghanistan until we have supportive government, so that we can optimise the benefits and measure the impact. So we hope that our learnings can be useful for other contexts. Thank you.
Thank you for the terrific presentation. This reminds me of my own experience with USA Suara 2. We did interactive voice response support for the family planning topic, and it was also quite, we were not willing to talk about family planning in public, so that aspect I think was a matter of success for us. Thank you so much, and I had so many, because given the Afghanistan situation, there are so many questions which I think will come from floor as well, or if not, I'll ask at the end of the session. Now I invite another presenter, Nilmini Jayalas. It's a very long name. Is that fine? Nilmini Jayalas from the YMI University of Sri Lanka, and she will be presenting on validation of an AI-assisted dietary assessment tool among adults and girls in Sri Lanka, a step towards scalable nutrition monitoring.
Good afternoon, everyone. I'm from Sri Lanka, and today I'll be talking on the topic validation of an AI-assisted dietary assessment tool among adolescent girls in Sri Lanka. So this is part of my PhD work, and also it's a collaborative project called Nudging for Good. Okay, so here you see a smiling group of Sri Lankan adolescent girls, the future of our country. Yet, behind these smiles, they face a hidden nutrition crisis. At the same time, before we design any program, guideline, or any school-based intervention, the first question we should ask, what does their diet look like? Unfortunately, we don't have up-to-date and reliable dietary intake data among this population. Traditionally, we rely on several methods like weight food record and the 24-hour recall to collect their dietary intake. But all these methods have their own limitations when it comes to the specific demographic. So this creates a need for an innovative, reliable, yet practical solutions. And that's where technology can help. So today, AI-based mobile methods are emerging as promising alternatives, especially in low-resource settings. So in this context, we developed an AI-based smartphone application called FRANI to track and improve the diet of adolescent girls. So this FRANI stands for Food Reconnaissance, Assistance and Nudging Insights. So we call it as FRANI simply. So this FRANI does two major things. First, it's a dietary assessment tool. Users just need to take a photo of their meal from FRANI, and it automatically tells what food item they eat, how much they eat, and how much nutrients, including both macro and micro, they can get from their meal. Second, it gives friendly feedback and healthy messages based on the dietary guidelines to nudge adolescents toward healthy food choices. But here, we basically talk about how FRANI works as a dietary assessment tool. So developing FRANI wasn't that simple process. Actually, it took more than 1 year. But for the completeness of the presentation, I'll briefly tell you how we developed the FRANI. So we went through several steps. And first, we created the comprehensive food database and image library. So where we prioritized most commonly consumed food items by Sri Lankan adolescent girls. And then we collected photographs to represent all these food items with a variation. So you can see here some sample photos that we collected. And at the same time, we cooked all these food items in our control laboratory to collect the recipe data. In the second stage, we trained the AI model using annotated images. So it's a technical process where we separately pixel of these images. And in the third stage, we developed FRANI integrating this trained AI model with the food metadata, including the food composition data and also the food images. So this is the main part of the presentation. So once we developed the FRANI app, we wanted to check whether this is a valid tool to assess the dietary intake among adolescent girls. So we did a validation study. Our aim was to validate FRANI against the gold standard of dietary assessment method, the weight food record, and also to compare its accuracy with the standard 24-hour recall method. So let's see how we did the validation study. So we recruited 60 adolescent girls aged between 14 to 18 years from northwestern province in Sri Lanka, and we collected their dietary intake data over 2 non-consecutive days using 3 methods: FRANI app, weight food record, and the 24-hour recall methods. For example, let's say you are one of my participants. An enumerator visits your household early in the morning to give you the smartphone with FRANI, and she waits with you throughout the day while measuring all the food and beverages you consumed, and simultaneously you should collect the data from the Franny app. Next day, a different enumerator visits your households again to collect the dietary data from the 24-hour recall methods. So the reference day for all three methods were the same, therefore it's directly comparable. So once we collected the data, we converted them into nutrients, and we did all the statistical tests through Stata. So here are the key results. So we assess the validity across methods, performing the equivalent test, where we compare the ratios of daily nutrient intake between methods. And here we used predefined equivalence bounds at 10%, 15%, and 20% based on the literature, based on the previous validation studies. So when it comes to the results, you can see when comes to Franny versus weight food record, the ratios for energy and vitamin A intake fell within 10% bound, and the ratios for other underlying nutrients fell within 15% and the 20% bound. So when it comes to the 24-hour recall versus weight food record, so you can see here, we couldn't find any nutrients fell within 10% error bound. However, the ratios for underlying nutrients fell within 15% and the 20% error bound. And also you can see for both method, Franny and the 24-hour recall, a few nutrients didn't meet the predefined equivalence bounds. So this can be explained due to the complexities in the recipes and also the portion size variability. Also, we assess the agreement between methods using concordance correlation coefficients. So you can see here, the CCCs between Franny and weight food record was slightly higher than the CCCs between 24-hour recall and the weight food record, showing the better agreement between methods. Also, we assess the sources of memory errors for Franny and the 24-hour recall, so where we reported both omission and intrusion errors. So here you can see Franny shows low omission and intrusion errors compared to 24-hour recall methods. So it shows the importance of real-time dietary monitoring. Further, we assess the sources of portion size estimation errors for Franny and the 24-hour recall for the most commonly consumed food items. Here we consider the food item as mostly consumed if it has the consumption episodes more than 20. So in this table you can see here the food items and the particular food group, and then the number of consumption episodes and the quantity consumed at once, and the final column shows ratios of quantities consumed. And here is the more clear graphical representation of ratios of quantities consumed. So it shows that Franny's estimates were comparable to the 24-hour recall method. So in conclusion, we could say Franny is a valid tool to assess the dietary intake among adolescent girls with accuracy compared to 24-hour recall method. And also by improving the recipe coverage and also the portion size estimation, we could enhance the performance of the Franny further. So this is not just a technical achievement, and it has a real programmatic value. So this Franny can support scalable, cost-effective dietary monitoring while providing more reliable data for the policymakers and the programmers to improve the diets of adolescent girls and lives of millions of people. So finally, I would like to thank all who supported with this work and all who supported to participate for this conference. Thank you, everyone.
Thank you so much for another fascinating presentation. Franny, I think it's something that combines everything that we aspire to when we develop digital solutions, like it has integration of AI, and it has gamification tool as well. So kudos to that. Now we move on to the next presentation, and this is also from Sri Lanka, Susanti Pereira, from the Wemba University of Sri Lanka. She'll be presenting on digital storytelling to promote healthy eating, magic creatures, and the Nutri-Garden for primary school children.
Well, stories can transform and transport us into vivid worlds. They have this magical ability to sort of shape what we think about the world, our lived experiences, sometimes the decision making, as well as how we just perceive the world. So we sort of tap into this exceptional potential of storytelling, and we wanted to see whether we can use this to enhance already taken efforts with respect to nutrition promotion and education. So that is what sort of inspired this small pilot study into look into how we can use storytelling as a tool to enhance the already taken efforts of nutrition education and promotion. So I want to begin this presentation by also sort of giving you an overview of what we did throughout this small project, and also to walk you through what we have achieved. So let me first set the stage as to like why we were working on this project. So to think about the Sri Lankan context, and especially because this study was focusing on primary school age children. And we were specifically targeting on this demographic because if you look at the current status of malnutrition, you can see this demographic is somewhat struggling with issues with respect to various forms of undernutrition, whether it could be stunting, wasting, or underweight. And at the same time, alarmingly, we see the rising rates of overweight and obesity among primary school age children. So this is something that we folks who are in the field of nutrition are trying to understand what is happening. But if you just look at Sri Lankan context again, our diets are increasingly shifting towards processed food. And we consume large quantities of refined grains with limited amounts of fresh produce. So again, if we think about the nutritional challenges that this particular demographic group is facing, not just undernutrition, but we see rising rates of micronutrient deficiencies, especially vitamin A, vitamin C, iron, zinc, riboflavin, thiamine, and few other micronutrients, vitamins and minerals that these children are lacking currently. And as I said, because we are shifting towards basically processed food, and we consume large amounts of cereals with less fresh produce, so we have to, we've been understanding that only about 1 out of 5 children who are coming from this particular demographic is actually fulfilling the recommended amounts of fruits and vegetables, which is a sad context, and we may need to figure out ways how to sort of tackle this. Now, I understand that the nutrition and health community has been, doing monumental work to address these challenges and coming up with different initiatives. But I think as researchers, it is our task and responsibility to sort of look into cost-effective, perhaps interventions that are more engaging and innovative. So that's where our thought process sort of shift into sort of leveraging digital tools and tapping into something that is conventional and traditional, the storytelling, and digitizing it to provide education about fruits and vegetables and the importance of their, especially their role in a healthy diet. And we wanted to target young children because, as I said, the previously, the information that I have presented to you, because we think starting from early about giving information with respect to healthy diets are something that we should focus on. So keeping that in mind, the objectives of the study were twofold. So what we wanted to do initially is that we wanted to develop an interactive package that consists of an audio digital storybook as well as a digital game. And then we wanted to look at, once we developed this package, we wanted to real-time test it with our target audience to see its usability, acceptability, relevance, especially with respect to primary school age children. But then to begin with, storytelling or creating content was something that was new to us as well. So it was uncharted territory. So going into that, we had to start from the ground up and we had to do a deep dive. So for the development phase, what we did initially was we wanted to sort of tap into like our stakeholders. That would be the children and the parents and also teachers, because these children spend a lot of time in the schools. We wanted to see the perspective from the teachers. And we did a series of focus group discussions. To be exact, I believe it was about 25 to 27 focus group discussions, basically to nail down what exactly should be included in a digital storybook that teach you about fruits and vegetables. So the themes included the challenges, specifically with respect to fruit and vegetable intake in this demographic, the young children, and what sort of elements that they would like to learn, and also about fruits and vegetables. And if it is a storybook, what sort of aesthetics or artwork or characters they would prefer. So we collected a lot of information with respect to these themes from by connecting with our stakeholders, and then we started putting together the storybook. So we did several rounds of going back and forth with artwork, the aesthetics, the characters, the storyline, and once we have a workable prototype, we put together an expert team, which consisted of several dietitians, an educational expert, a child nutrition scholar, and a child psychologist to do an expert review on the sort of look at the elements that were used in the storybook, as well as the digital game. So once we receive their feedback, then we sort of finalize the storybook, and then we wanted to straight away go into evaluation. So this is sort of this is what we came up with based on the focus group discussions and the elements that we have identified. So we wanted to sort of give an interesting name, because we are sort of sending this out to young children, and they are supposed to accept the storybook as it is. So finally, we came up with this idea, Magic Heroes and a Nutrition Garden. So I will give you a brief glimpse into what we have created here. So this is actually what is playing right now. Here is the part of the game, and I'm going to show you a sort of a brief overview of the storybook. Now I apologize, this is in the local language. We did not translate this yet, but you can see the artwork, the characters, and the overall sort of overview of the book. So the book has two protagonists, a girl and a boy. We wanted to not to discriminate based on the gender, and based on what children told us from the focus group discussions, they wanted to have creatures that are magical and also more engaging. So based on that, we created this artwork, and these artwork were actually created by my student herself. So she drew every single character and the flow, as well as flow of the book, as well as the digital the game, some of the concepts of the game, and then we had to tap into a computer science specialist to put together the game, because we did not have that, that skill to put it together. So that was pretty much about the sort of the development, and then we sort of wanted to evaluate this, so we sent it out to children for 4 weeks to look into the game, play the game, and go through the read through the storybook. We did not find any substantial changes in the consumption, but we saw the children's preference for certain fruit and vegetable items were increased. So they were happy to consume more fruits and vegetables. So overall, everyone preferred the book, at least based on what we have, from the group that we got the feedback. And as to the way forward, what we would be preferred to do is to make sure that this is more interactive, functional, so we have to think about the scalability and then perhaps multi-sectoral approaches to improve this storybook. So I think with that I will conclude my presentation. So I'd be happy to thank everyone who helped me to be here and sort of allow me to present this. But if you have any further, if you'd like to connect with me, I'll be here and I'll be answering questions. So I'm happy to tell you more about what we have completed. And with this, I will conclude the presentation, and thank you very much for listening.
Thank you. This presentation highlighted the rigor that takes to develop social and behavioral communication intervention. We have many of us have been through that, and thank you for bringing that. Now we are moving into the next presentation. And I'd like to invite Jahid Memon from Aga Khan University and presenting on Majboot Bunyad, early outcomes of Pakistan's first digital nutrition registry for malnutrition management. Okay. So Warda Ahmed, sorry. Thank you.
So hello and good afternoon everyone. I know it's a very tough session after lunch, so I'll try my best to keep as interactive and as engaging as I can. So I'm Dr. Warda Ahmed, representing Community Health Sciences Department, Aga Khan University, Karachi, Pakistan. So I'll talk about the Pakistan's first digital nutrition registry, which we have implemented in Pakistan, and it named as Majboot Bunyad. So Majboot Bunyad means a strong foundation in English, and in Nepalese it is called Majboot Aadhar. So I'm very much thankful to my principal investigator, Dr. Zahid Memon, and my team, Shifa Habib, Amara Ali, and special thanks to the field team and the grant administrators and graduate students who have participated in this project. So moving on the background, so everybody's talking about stunting and malnutrition since yesterday. So we all know, but important to note that 50% malnourished children in South Asia resided primarily in Pakistan, Bangladesh, and India. So why? So we implemented this registry in Sindh. So Sindh is the province of Pakistan out of 4 provinces, and it is highly burdened with malnourished children. Like out of 4 children, 1 is acute malnourished. So why the integration of nutrition and with immunization? So this is a very important model, and where we encompass the public and private engagement as well in Karachi. So why the urban setting? Because it's a huge migration and urbanization in the cities, in the major city, and there's a lack of health infrastructure and lack of private sector involvement, despite the fact that most of, like 70% of the population is going to the private sector. So still we are lacking with their engagement. And yes, of course, there's a gap in vaccination coverage. So we will see how the vaccination is actually giving the pulling effect and the pushing effect with the nutrition. So the intervention model was co-designed by the government. Like without government, we cannot implement these kind of registries. So we integrate immunization and nutrition services, and we include 33 private providers, clinics to serve in the catchment population of 8 high-risk unit councils of Karachi. They are categorized as per the polio program. So we included private providers, and there were set up of the child-friendly routine immunization services with the integration of screening of nutrition, counseling on breastfeeding, wash, and obviously hygiene and sanitation. So this is the geographical distribution of the facilities where we have worked with the public facilities, private facilities, and other EBI centers as well. So this is the main model where the Aga Khan University becomes the central, and we have connected the private providers with the district health authorities, so which is very important. So we worked in the supply side as well and the demand side as well. For the supply side, we connected and advocate for the supply chain management in terms of vaccination and immunization, and for the demand side, it's a very interesting interventions we have implemented. These are the community engagement activities which are health mehfil fill and help methods, and digital communication, obviously, with the people around through WhatsApp broadcasting, and involvement of the private providers, which really increase the patient footprints and client footprints in their setting. So when we talk about the lollipops and the win-win situation for the private providers and what are the incentives we can use, so I think this is a very good step that proven in our context. So why the nutrition registry? So as I talked about, there are 70% people going to private sector, and then they are undocumented because there is no proper documentation of the private sector, especially in our countries. So there are different market barriers, as I say. So there are lack of focus on preventive treatment, there are lack of monitoring and supportive supervision, there are high costs in private sector, so poor quality of services. So what we did, the intervention is basically the integration, and it mainly focuses on the assessment by the trained nutrition counselor, and then reviewed by the specialist in the nutrition, and then the supply chain obviously integrated with the IFPRI and MNP, given to the student, given to the patients, and then there will be a follow-up mechanism which is very successful, and then the referrals for the nearby providers. So the impact is very important. So we all talk about the numbers and everything, but there is I will show you later on how the community actually trusting this model, and it increases the quality and diagnosis of the care, and decreasing the burden of nutrition in the catchment population, and obviously the long-term sustainability through public-private partnerships. So this is a brief overview of the services. So this is the dashboard, how it flows. The child is registered, and then screening, the inputs of the screening reports will be conducted by the field team, and then follow-up mechanisms, and then referrals, and then they were categorized according to the algorithms. So there are very technical terms. So that was used. So I'm talking about the results. So this is the demographic distribution of the children under 0 to 59 years of age, and during 1 year we have screened 22,443 children. So this I'm talking about this graph. So the registration and the enrollment of through this digital nutrition platform in 1 year, I think this shows community trust and how they are actually coming to the centers, and then enrollment and the services also increases, and the people are also gaining treatment and management for their undernourished child. So moving on, the nutrition status of the enrolled children. So 80% were normal, there were 14.5% were MAM, including the moderate acute malnutrition, 4.5 were severe acute malnutrition, and then overall is 19% malnutrition. So this table shows that there were only we enrolled moderate acute malnourished child, which were 3,259, and out of that only 7.3% was lost to follow-up. All other child was actually followed and referred to the management centers. So this is about the SAM. So this graph is very important when I talk about the estimated effect of immunization and the uptake of nutrition. So number of children in Panta 1, so the Panta 1, Panta 3, and MR1 increases after the post-integration with nutrition. So mother usually come with my child is so weak. So people, they are not more focusing on the immunization side. They are more focusing on the weakness of the child. So this is, I think, is a very full effect when we talk about the integration of nutrition with immunization. So implication for scaling and policy, obviously this is an early success. I'm not saying it's a pilot, I'm saying it's an implementation, because it's actually the region-specific and system-level change that we are proposing with the government, and the government actually sharing the IFPRI, expanded program of immunization, share data, and how we validate this data. And there's a huge potential for scalability and importance of digital tools. So together, nutrition, immunization, digital systems, we can really do a possible change in our context. So and I'm very thankful to all the partners and who supported us, especially World Bank and the funder of this project, Gates Foundation. Thank you very much.
much for another fabulous presentation. We also saw how the private sector can be engaged involved in managing malnutrition. That is what I think many other countries are competing, are trying but not being successful. That will serve as a case for us. Nepal as well, we're also been since long been trying to involve private sector in malnutrition management. And with this we come to the final presentation of the session, and I invite Jishan from the New Delhi Institute of Management, presenting on digital convenience, dietary consequences, how online transactions drive processed food consumption and medical expenditure.
So, hello everyone, good afternoon. I am Zishan from New Delhi Institute of Management. This study is done with one of my co-author, Dr. Tajuddin Khan. He must have joined us online from Roanoke University, USA. This presentation is a bit exceptional in two, three ways. In the sense I am the only poor male presenter among the four extremely intelligent female presenters. Another one is this study is based on the secondary data. We used the NSSO 7, NSSO, most recent NSSO round that was done in 2023. So we done on urban India only. So I mean, all the presenters have presented the on-ground, on-field studies. In that way, our studies is exceptional. I don't know if it's good or bad. The third one is what was the third one? I forgot. So, so let's begin with the presentation. All right. Yeah, third one I remember now. Okay, so I am extremely sorry that I don't have the direct solutions for the problem that is discussed, or I am going to discuss the problem, unlike my friends discuss. But I will be preferring to, emphasizing more on the dietary consequences due to the digital convenience we have nowadays. So, which will be emphasizing on the real-time solutions that my friends discuss. So, it will be more emphasizing on the requirement of these solutions rather than the providing direct solutions. All right. We know that processed food and ultra-processed foods consumption is increasing, and India is not the exceptional one. As per the reports of Niti Aayog, WHO, and some independent researchers like Professor V.M. Bansal, Tina Singh, Gauri Modwal, there are about 20-25% contribution from the processed food as far as the total diet is concerned of an individual urban Indian. And we do have this strong literature available which shows that there is a positive correlation as far as the higher processed food consumption is concerned with the obesity, metabolic syndrome, cardiovascular diseases, and heart attack, etc. On the other hand, if you see the digitalization, digital revolution is experiencing in India, not only in the urban India but rural India as well, especially after the COVID-19, or even I would say after the demonetization that happened in 2016. If you go to India, you will find that even a small shop owners, even the fruit and the vegetable vendors will find the QR code where you can scan and pay extremely easily. And after the COVID-19, we have experienced that you can order your food, any type of food using the variety of apps that we have, Swiggy, Zomato, or for the q-commerce options that we have like Zetaro and Blinkit, Instamart, even Amazon Fresh and others. So we just wanted to see how the dynamics of online processed food is playing an important role for the dietary patterns in general and the processed food consumption in particular, and how we can link them with the health, medical health expenditure. Before we jump to the online dynamics, I would prefer to emphasize on what WHO or the Lancet recommended for the variety of foods that we have, and what an average urban Indian is consuming. So I mean, whole grain is fine, 32 to 40% it is recommended, and 43% that we are consuming. And about 99% are those who are consuming at least 10% of the whole grain. But when we focus on the fruits and veggies, 8 to 12% and 6 to 10% are recommended for veggies and fruits respectively, but hardly 3%, 3.37 specifically we are consuming for veggies, including the veggies that are used for making our curries and variety of curries, and hardly 2% of fruits. And once we go for the at least 5% of consumption or at least 10% of consumption, we'll find the exceptional numbers, like 17% only are having the 5% of veggies, and once we go to the 10% threshold, it is almost negligible. We can also focus on the protein, which is recommended about 12 to 20%, and hardly 6% that we are consuming. Now we can focus on the processed food. I mean, though it is recommended that we shouldn't consume the processed food at all, but nowadays it is difficult. So there is a threshold that okay, you should not consume more than 5 or 6% of it. But we are consuming about 19% of processed food consumption, and about 80% of us are consuming at least 10%, which is about more than double. Okay. So these are the box plot that we have where we are introducing the dynamics of online food purchase intensity. We use online food purchases binary form as well as the intensity, where we are seeing how much you order food online. You might be noticing the three type of dotted lines: green, red, and blue. Red dotted line is the lowest threshold, and upper threshold is by the green dotted line, and the blue dotted line refers to the maximum threshold that we could have, where you can find in food whole grain. Those who are ordering online more, then they are having lower than the mean of the threshold level. But when we focus on the processed food consumption, no one, even those who are not ordering at all, their mean is also higher than what we are recommended. All right. So we used the variety of dietary diversity indices. Some of them are extremely established one in the literature, like Simpson and Shannon. So we standardize them so that we can compare well. And we also use the threshold of 5% and 10%. Usually in literature we find that even a negligible amount of consumption is done in a particular food category, we consider as the occurrence of or one usually. But we thought that if you are taking the negligible portion from a particular food category, we should not consider it at least 5% of it, at least 6% of it. We do a hit and run trial of this. We use different threshold levels like 4%, 8%, 7%. But for the comparison purposes, we stick to the 5 and 10. This is the framework that we used for our study. The exogenous factors like tower density in a district, which is a proxy of connectivity, and the other factors like night light, which is a proxy of economic development, and the adoption rate, not only for the binary nature but the intensity nature as well. Together construct for the digital infrastructure, which is likely to lead for the online food purchasing, giving the other factors like income, education, caste, religion, employment, etc., and which likely to lead to the dietary pattern and the health outcomes. Okay, so this is also interesting. Based on the threshold level that we discussed on the earlier slides, we have given minus and plus. If you have consumed in a given threshold, then a plus, otherwise 1, and the summation of those variables give us a dietary score, which ranges from -3 to +5. -3 refers to the extremely unhealthy diet that we are having, and the +1 refers to the extremely healthy diet that we are having. Alright, so we started with the OLS regression so that we can see whatever we are getting from the descriptive statistics, how relevant it is, how significant it is, can we trust them or not. and we found that online, those who are purchasing online, they are having the higher expenditure on processed food, they are expecting higher calories from the processed food, and we used 6 different outcomes. I'm running out of time. For the eligibility purposes, we use the instrumental variable as I just discussed. So it is giving the significant relationships. The signs are same, significant level are same. Only the magnitude has increased as compared to the OLS. So OLS is a bit underestimated. IV is likely to give us better estimations. For the robustness, for the medical expenditure, we used how the processed food is contributing for the higher medical expenditure, and we compare the OLS as well as the IV, and given other control variables like how well they are, their age, education, caste, marital status, economic status, etc. For the robustness purposes, we use the intensity as one of the independent variable other than except the binary, and we also compare the 2LS and we also compare OLS with the target for the robustness purposes, so that we can be sure what we are getting is trustworthy enough. All right. As we just discussed, online food purchasing in urban India is strongly linked with the higher processed food consumption and higher calories from the processed food consumption, and likely to increase our medical expenditure, not in short run or in the long run. And digital convenience is shaping our diet very fast, but unfortunately in a negative sense, because we are ordering unhealthy food, not the healthy food. Thank you very much for having me.
Not for me to say, but I think we did a pretty fabulous job of making sure we had a wonderful lineup of presentation. I remember my father carrying a pager when I was 6 or 7 years old, and then carrying a brick for a mobile phone, and now us all being digitally connected on our mobile phone. Every day we bombarded with so much information. We've come a long way, and to see there's so much innovation happening across the board when we are talking about how we are leveraging digital tools to deliver impact at scale, both for diet and nutrition. Thank you so much to the presenters. If we can have a round of applause for all our 5 presenters. If I may invite Veena Matheson, Nilmani Jayalak, sorry if I'm butchering anybody's name, Tushanti Pereira, Warda Emma, and Zisan up to the stage. We'll be opening up the floor for questions. If you have questions for a particular presenter, please take up the mic in front of the room, come up and ask questions. Please mention the presenter's name. I think we have participants online. Okay, sure. I think we already have someone up there. We have a small room, so I think our voices are big enough, but if you don't mind using the mic. Sorry, just if you can hold off, let them just settle down because we can't hear your question.
Lilmani, this is for you. So you have mentioned that the Franny not capturing that 2% of the diet that they are having, and some 7% of reporting that they are not consuming. Have you find any uniformity of this inclusion or exclusion among the participants sample? Because we just want to understand. We are trying this kind of technologies in our area. We just want to understand what kind of food items that they are not reported, or they reported but they are not consumed. That's fine.
If we have few more questions, we'll collect and then we'll open the floor. We have someone else.
Hello, my name is Ashma Tahar, and I'm from Thematic Academy of Health Sciences. My question is for the gentleman.
The only gentleman.
The only gentleman. he talked about calorie consumption in his presentation. I would like to know more about that. What was the measure used for calorie counting in your research? Thank you.
Laurie Miller from Friedman School at Tufts University. First of all, a compliment. Ilmini, I think that's super exciting. And that's going to be the way that people are going to be collecting data about diets from now on. I think that whole method is going to replace what we've been doing so laboriously for so many years. So thank you for that.
Thank you so much.
And also to the gentleman, you went quickly through the regression slides. So I was just posing the question that perhaps there's a reverse in the causality. Maybe people with higher medical expenditures are home and unable to go out, so they're ordering food in that way because they already have a medical condition that prevents them from going to the market. Thank you. Any comments on that? I appreciate it.
I'm Dr. Shobha from, I think it was not the height. It's not working. Anyways, I'm
No,
Dr.
it's
Shobha
working.
from Observer Research Foundation, and I have a question for Zishan. I think it's the right time to talk about processed and ultra-processed foods. I just wanted to know what is the definition you took for, categorizing the processed and the ultra-processed foods. And secondly, what were the health metrics when you said that the expenditure on health went up? So what was the health metrics that you used to calculate the expenditure on the cost of the imported health?
If I may, you can hold off on the questions so that they don't forget the questions that were asked. If you want to deal with the question first, and then we can go to Zishan.
Okay. Okay, thank you for the question. So this question was on the omission and intrusion errors and what food were the omitted and the intruded foods. So I here basically I will talk about the Franny, and so you saw that Franny shows low omission and intrusion errors, and so this is because it's a real-time dietary monitoring. And so here our sample was the adolescent girls, and they are normally in daytime they schools, and they are went to the tuition classes, and it's very hard to follow those our participants. And here the omission means the food items not it means not included in the weight food record but not reported in the Franny. So those food items are mostly the packaged food items. So in this Franny app, so you can also imagine that it's how much hard to train the app for the packaged food items. There are a lot of variations there. So in Franny we add an option to add those food items manually, especially the dairy products and the biscuits and snacks. So these students might forget to add these food items. That's for the reason for the omissions. And for the intrusions, some might that means the food items not included in the weight record, but they are reported in the Franny app. So because in the daytime, when they are at the schools, it's difficult for enumerators to follow those students throughout the whole day. So that's why for the reason that food items are not recorded in the weight food record, but recorded in the Franny, because as in the manual adding option, so the girls can add those food items manually when they get back to home. So that's maybe the reason for those omission and intrusions.
Thank you everyone for the questions. I'm like exceptional in having the questions as well. Okay. The first one was related to calorie consumption, how we have calculated. So in NSS, we have hundreds of the type of foods that people are consuming. So once the server born, they ask how much you have consumed, which food is consumed. We have that information. So out of the quantity that they are consuming, we have calculated the calorie that they can extract out of that food. Okay, let's say if I am consuming 1 kg of rice in a month, so how much the calories can be consumed. So in in that way, out of the quantity, we have extracted the information of the calories, and then it was adjusted with the number of households they are having and the number of days in a month. So in that way, we have calculated his calories per person per day. Sorry? It was estimated first. All right. Then from the ma'am related to the reverse causality, of course it can, and it's an ongoing process. I mean, once we first we started the association base. I mean, how the online purchase of food is related to the processed food consumption and then the medical expenditure. So we just explored the association between these two and more variables. Of course, we are exploring the reverse causality by using the PSM and the other techniques. So that we can say these are the causal. I mean, as of now, we are not claiming the causality, we are claiming the associations. Then we have definitions of processed food and medical expenditure. So for the processed food as well, they have given a particular block for the processed food, the type of processed food, the served one, as well as the packaged one, where the pesticides are used, where the shelf life is given. So such type of foods are given for the processed food. We just combine the quantity as well as the calories and other stuff. And medical expenditure, they have given the out of expenditure. Out of pocket of expenditure for the recall period of 1 week and 1 month and year. So we just standardized this for getting the medical expenditure for a month.
Thank you for a wonderful presentation. My question is also to Nilmini. It was really interesting presentation. So in your presentation, you said this Franny tool is the kind of valid tool. But I'm curious to understand how many pictures were trained through the machine learning process, because in one of the machine learning work that we are piloting here, we trained around 70,000 of images, and those were still valid only up to 80%. So I'm really curious to understand that. And in terms of cost, like really curious to understand how much it costs to develop that app. Yeah, thank you.
This is Afjal from IIT Bangladesh. So I would like to thank all the presenters for your nice presentation. So my question to Perara, storytelling, yes, from our boyhood, we know that storytelling is the best tools. I want to know from you, is there any change in case of food habit by telling the story? Just for example, say I like radish, but due to story, now transfer into carrot eating. So is there any, what are the percentage? Have you measured it? The Nilmani, really, I like you to presentation. So you have, yes, received a good result, but have you actually see the change level at the practice level? How it is actually changes at the practice level? Maybe you would get the good result from the respondent, whether it change in the transform in the practice level. That is my question. And also for the Rina, yes, you have a very good message. Same to you. Whether have you actually got responses from the any change at the practice level? You have the good message, but if there is no change at the practice level, the only message does not actually mean anything. And for the Varda, yeah? Yes, we are also practicing and try our best level to engage the private sector, but still there is a lacking. But you also mentioned, yes, there is a lack, but their participation, engagement is necessary. So is there any lollipop, how we can actually engage them, so that because without them it is very difficult to implement as expected level. Is there any key points? Yeah. And for the doctor, you said maybe not the good presenter, but really you are a good presenter. Okay. So we find in Bangladesh also, we use the cereals more, but vegetable fruits is better. I also seen in your presentation. So why it is? It is unavailability or the misinformation or lack of information or family practice? Why the fruits and vegetables intake is less? Thank you very much.
I think my curious colleague Maiji has asked a lot of questions to the panel. We'll take any last questions. This is probably the last round of questions.
So
I have a
if
question.
if you could kindly keep it to just one question so that we're being inclusive. Thank you.
I have a question for Rina. So how did you manage, how did you navigate through the regime change? You mentioned about that in your presentation, and how did you convince, that you also mentioned that it was very hard for women to work in those settings. So how did you convince the leadership, and so that I think it will be very useful if you share the experience. Thank you.
We're going to pass it on to the panel members. Now, if you're curious, they're here beyond their session. Please have conversation with them. With that, we'll pass it on to the presenters.
Well, very quickly, because we have limited time. So we included a list of fruits and vegetables to be included in the storybook so that we can have a wider coverage and exposure to different types of fruits and vegetables from this, the intended target population. Because the intervention took place about a very short period of time, for about 4 weeks, we did not see much increase in the consumption, but what we have seen is a change in the preference. The children were more inclined to try at least a little bit more of fruits and vegetables, and they were more curious about trying different types of fruits and vegetables because the book sort of gave them the importance of different micronutrients that you can get through different fruits and vegetables. So we are sort of going through another round of data collection with a longer period and changing the list of fruits and vegetables. We wanted to see how what sort of an increment we would see in the amounts that they would consume, as well as what you said, the shift in the preferences, whether they were picking something else and replacing it, so that we did not actually look at this very short period of study, but that is something that we wanted to discuss because we have seen that some of the shifts happening in the preferences. So I would stop with that because other panelists would need to explain their answers. Thank you.
Okay, thank you for the questions. And regarding the number of images, so our target was to collect at least 50 images per food items, and we collected more than 10,000 food images for the trained AI model. And regarding the real practice of the Franny app, after the validation study, we did the pilot study to assess the effect of the nudging, and also to do some qualitative study in the focus group discussion with our participants to see whether it's acceptable or likable and whether it has a real implement. So we actually in these days we are in the process of data analysis, but based on the preliminary results, we could say it works well and it has an effect on the real practice. Thank you. Okay, so actually we didn't analyze the cost, but yeah.
Practice change is difficult to measure anytime, anywhere. I agree this is a flaw, but I think our intention in Afghanistan was more about accessing people and maintaining access to a particular message, and we were assessing the palatability of that message under the new regime. So from that perspective, we were happy that there was anecdotal evidence that people were happy with the message, anecdotal evidence that there was practice change. We have an end-line project survey that shows that the minimum dietary diversity for women has improved. We have 15% persons with disabilities included in all of our activities, and those persons are included. So we've got the anecdotal evidence that it worked, but I agree we don't have the data, the research level data. How did we manage the regime change? Yeah, no, I'll answer very quickly because I just want to say, like, the biggest issue is the Taliban's ban on women working. That's been very difficult for us. That happened 3 years ago. Initially, we paused and closed our office for 6 weeks and stopped distribution to 70,000 people in protest. That was ignored by the authorities and others. We then reopened our offices that were Sharia compliant, so we have a female wing of the building, a male wing of the building, with the women coming in separately. And basically we work case by case. So we negotiate access wherever we can, we don't ask for permission, we apologise later, and we try and assess each commander, each level person, how dangerous are they and what are the implications going to be for this woman. So we have donors that say you must work by women for women or we won't give you money, and we have a government saying we'll throw you out of the country if you work with women. It's a very small space to be working in, but we're all there and we are reaching women, and in the grey, as long as you're not blatantly shaming publicly, as long as it's quiet and underground, we can get quite a lot done.
Thank you. So I'll be very quick. So I'm not saying it's lollipop, I don't like that word. So I'm like more towards the south vein, I think. So the two main strategies that we have used, so the general practitioner, the private providers in the catchment area, so they are the local providers, people trust on them, they are the family doctors. So we recorded their videos and where they are promoting the nutrition and immunization together. So that's so everybody want to be on a screen, to be highlighted in the area, so they really appreciate it. And we also arrange the need-based training in Aga Khan University for those providers. So we assess them what they need to be trained. For instance, they need to be trained on simulations for certain IV insertions and all that. So we have arranged those trainings in Aga Khan University and provided them the CIME, that is continuing medical educational credit hours to them. So that's a very good win for them. Thank you so much.
Sure. So why fruits and vegetables are not consumed in India? And that is not the case in India only. I mean, in Bangladesh, in Sri Lanka, even in Pakistan, you'll find this. I don't think there is a problem of availability, because we do have the availability of fruits and vegetables. Even we export, I mean, a lot of fruits and vegetables. We are among the top 10, if not 5. Affordability could be one of the reason, because the average price of the fruits are much higher than the average price of the whole grains, and awareness could be one of the problem. Like we don't know the importance of having fruits in our breakfast. We don't know the importance of having a bowl of salad before our lunch or dinner, how it can serve us. So those who can afford, they may not be aware, and those who can't afford, they prefer to afford the whole grain first before the veggies and the fruits.
Thank you. We want to make sure that we are on track, because we know we have all other commitments and other presentations to go to. I'm sure all of you agree that we have great presenters here. Final round of applause for them, for their incredible work. And adding the piece of puzzle, as I was mentioning, to this digital solution that we speak of. Hope you continue this conversation beyond this room and beyond the conference about how we can wield digital power. With this, thank you again. Maybe you can go back to your seats if you're more comfortable there. If I can invite my co-chair Indish Chetri for his closing remarks on here on the podium.
Thank you. I'll try to be as brief as possible. I know the chairs are emptying. So what we eat is not just what's in the plate or what we order at the restaurant. It has a history, several customs, evolved through ages of our interactions with it, and made better by humankind's persistent efforts. Its economy and its political, and that has also been presented in the presentations that has been covered. There are constant innovations to increase production, make the food more nutritious, diverse, and accessible. Digital solutions are the most promising, yet not averse to challenges and potentially a negative outcome, which also some of the presenters have highlighted. With the rise of the artificial intelligence, these risks are only compounded. In this session, we have heard about the best practices and some efforts to overcome the challenges and potential negative consequences. I thank all the presenters for bringing the insights and participants who sat through the session and those who asked pertinent questions. There is a popular adage in Sanskrit, Vade Vade Jayate Tattvabodha, or meaning, through debates and discussions, we will find the essence. And this conference is an effort to find the most cost-effective and impactful interventions through the conversations and sharing. We will continue the conversation and persistently endeavor to improve the nutrition of our people and make it a better world. I would like to thank IFPRI for bringing us together for this Delivering for Nutrition conference, I think 8 years in a row now. I'm proud to represent Helen Keller International, which has been a part of this initiative for at least 4 years in a row now. I'd also like to thank all the co-hosts of the conference and for their enthusiasm and commitment, and the number of co-hosts keeps increasing every year. That shows the large support that we are getting for this type of exchange. And also thank you to the wonderful session manager Julie and everyone behind this desk. Thank you.
Thank you very much again. Thank you very much, Indra and Prajuna, for your wonderful moderation. And the presenters, I'd like to invite the presenters on the stage now for your certificates and a photo, as well as the chairs as well, if you'd like to join them. And our next session starts in 30 minutes, and it's going to be in Bagmati Ballroom. I hope you have some tea and then refresh and re-energize. Thank you so much.